So today we have the privilege of having a visitor, and he's a physician, cardiologist who have trained with Hamilton as well as Ottawa Heart, and so we're very privileged to have him visiting us from Saudi Arabia. Is Dr. Ibrahim Albakri from the hospital. Let me try. King Fahd Armed Force Hospital. Yes. I had to practice that. And Jeddah and Saudi Arabia. He's going to share with us about hypertrophic cardiomyopathy from echo perspective. So without further ado, I'm going to have him take over. So please go ahead.
Thank you so much. Good morning, everyone, and thank you for joining us today. So I have no potential or actual conflict of interest in relation to presentation. So my reference for today's talk is the 2024 Canadian guideline for the hypertrophic cardiomyopathy, along with the American Society of Echo 2022 for echo, and 2024 ACC/AHA guideline for hypertrophic cardiomyopathy, and the state-of-art review for the role of submitral apparatus in HOCM. So to start with, the definition of hypertrophic cardiomyopathy is actually having an LVH of 15 millimeter or more anywhere in the left ventricle in the absence of other causes of hypertrophy, a cardiac cause, a systemic cause, or a metabolic disease that's capable of producing such magnitude of hypertrophy. So it's now more and more recognized, and the prevalence is around 1 to 200, up to 1 to 500, and effective diagnosis and treatment has significantly reduced the disease-related morbidity and mortality. So before we talk about the disease, we're going to talk about the clinical profile, but we just need to be aware that this profile is subject to evolution over time, and patient actually can have more than one profile. So the patient can be either stable, benign, in a benign clinical profile without need for any major treatment intervention, or the patient can have LVOT obstruction that pushing him into heart failure and needing a septal reduction therapy that will be really helpful to take the patient out of heart failure. Or the patient can have a risk of increased sudden death and need for an implantable cardioverter defibrillator. Or patient can be at higher risk of developing stroke from atrial fibrillation and need anticoagulation for that. Or the patient can develop end-stage heart failure where they actually need a consideration for advanced heart failure therapy. So the approach to patient with hypertrophic cardiomyopathy is subdivided into multiple levels. So identifying the patterns first, then the level of obstruction, then if there's a patient having obstruction or not, assessing the MR severity and etiology, risk stratification, and differentiation from mimickers, and identifying the phenotypic expression of hypertrophic cardiomyopathy. So the most common type of hypertrophic cardiomyopathy is having the basal anteroseptal wall, which is the sigmoid septum. However, the patient can actually have different type, like the reverse septal curvature, like in B, where you can see actually the mid segments are actually more hypertrophied rather than the basal segment. Or the patient can have the apical hypertrophic cardiomyopathy, or the mid-cavitary obstruction, as in this picture with contrast, or the patient can have a concentric neutral type, in which like both walls, all walls are actually thick equally. So we talked about the definition of hypertrophic cardiomyopathy. It's 15 millimeter anywhere in the heart. However, the average thickness historically is actually having it between 21, 22 millimeter. And we also need to know that if the patient have a family history of hypertrophic cardiomyopathy, or they have a typical dynamic outflow obstruction, or they have a clear abnormal ECG pattern, having a 13 to 14 millimeter can be diagnostic for such patient. So we talked about the pattern and the thickness. Now we're going to go to the next level. So always comes to mind when we talk about hypertrophic cardiomyopathy is the having the SAM, or the systolic anterior motion that actually pathognomic for the disease. However, we can see it also in other disease, so it's important to differentiate that as well. So that's a typical picture of hypertrophic cardiomyopathy, in which we have a basal segment that's thick with as you can see here, the anterior leaflet get dragged toward the LVOT, and that, of course, gonna cause flow acceleration at the LVOT area, and it will cause a posterior directed emergent. So we have two mechanisms for the LVOT obstruction. We have the septal hypertrophy with narrowing of the LVOT, which leading to the abnormal blood flow vector that dynamically displaces the mitral valve leaflet anteriorly. And we also have abnormality in the subvalvular apparatus and the mitral valve itself, which we're going to talk about in details, but basically having a longer leaflet, abnormal anterior displaced pulmonary muscle, and abnormal mitral valve apparatus that all help to develop that SAM or systolic anterior motion. So it's important to know that we do have SAM and we do have chordal SAM. So valvular SAM, which is the systolic anterior motion involving the body of the anterior leaflet, but we also can have, due to bulkiness in the area, we can have just systolic anterior motion of the chordal apparatus or the chordal tendon that actually also can contribute to obstruction. So we mentioned that it's important to find and look for SAM. However, we can find systolic anterior motion in different diseases, like in patient post-acute myocardial infarction involving involving the apex with hyperdynamic basal septal hypercontractility, or in patient with Takotsubo cardiomyopathy with hyperdynamic basal LV function, or up in patient post-surgery after surgical and percutaneous mitral valve repair. There's multiple actually differential, including anemia, volume depletion, and tachyarrhythmia and sepsis. But this is a list that can show you that we don't only see it with hypertrophic cardiomyopathy, but we can see it also with other disease. And in order to identify SAM, so usually there is multiple ways. So in the M mode, we need to actually look for it. And the trick actually to look at systole, and usually we mark systole in echo and ECG from the QRS until the end of the T wave. So basically after the E and A wave, we look for additional part here, which you can see that the anterior mitral leaflet actually get dragged during systole and blocking the exit of the heart. So it's actually causing obstruction. If you're doing it in 2D, you actually need to scroll slowly so you don't miss some. Typically, we look for it in the parsenal long axis and in the apical 3, but you also can see it in apical 5, and sometimes even in apical 4 in some of the view. So also we need to grade that level, grade that obstruction. So the way we grade that obstruction in the M mode by actually looking at the SAM septal distance, how far it is from hitting that septum, the anteroseptal wall, and also the duration and the contact, is it happening through the whole systole or not? So we call it mild SAM if the septal distance is more than 10 millimeters, so it's far away. We call it moderate SAM if the septal distance less than 10 millimeter, or equal to 10 millimeter, or there is a brief septal contact less than 30% of the systolic duration. And we call it severe SAM, obviously, if you have a prolonged septal contact that's lasting more than 30% or more of the systole. And in order to quantify that obstruction, so we call the patient to have an LVOT obstruction if they have 30 millimeter peak gradient or more at rest or during provocation. So it's important to know that third of the patient have a resting obstruction, and another third have a provocable obstruction, but it's only happening during Valsalva or during dynamic maneuver or with exercise, and third have no obstruction. And on those patients, we need to follow, because if the patient does not have an obstruction today, he might have it in the future. So we talked about the definition is having 30 or more defined obstruction, but usually they do the septal reduction therapy when the patient have gradient 50 or more. So usually 50 or more is actually more attributable to having symptoms. And it's important to know that LVOT gradient can be dynamic and can be missed in resting echo up to 50% in patients with obstructive physiology. So if our patient does not have an obstruction at rest, we need to do provoker maneuver like Valsalva or with stress echo in order to trying to find that obstruction. In addition to that, we also need to know that postprandial actually can help to diagnose a lot of patients. So as you can see in this paper, this patient, despite doing exercise, they did not find significant obstruction. However, after they feed the patient, due to splanchnic dilatation and increased cardiac output, that can mask an occult gradient. So the way we approach it, so we look for resting gradient. We need to make sure whenever patient we have suspicion of hypertrophic cardiomyopathy, we look if the resting gradient 50 or more. If not, then we do Valsalva. If not, then we do a stress gradient. If not, then we can consider cath to look for cath gradient. So we identify the pattern, we identify if there is obstruction or not. Then we need to go to the next part to identify the level of obstruction. So usually, patient can have LVOT obstruction. However, they can have multiple levels of obstruction. And the way we do it, we map the LV. We actually go from the top, from the apex, and we go down and we pulse it from the apex down to the LVOT in order to see if it's elazing and hitting a wall like this picture. And we also look for flow acceleration, like you can see in this small picture. My apologies, maybe it's not really clear here from this picture. But as you can see here, there is a flow acceleration, and there is, from the pulse wave Doppler, you can see the flow, like it's actually near the LVOT. And it's also important to know that after we identify the LVOT obstruction, we need to discriminate contamination, which is mitral regurgitation. So mitral regurgitation is common in such patients. And the way we actually do it, we move the transducer toward the LVOT, and we actually mark that picture to be LVOT, and we actually write it on the picture that this is the LVOT frame or the LVOT picture. Then we move the transducer toward the MR, and we actually trying to bring and differentiate an MR from LVOT. So there is few tricks to differentiate that, other than the angle and the direction of the from that sweep. Also, you can here look from this picture to the left that the MR velocity is very high, like here up to 6, while the LVOT is actually usually lower. Actually, and in addition to that, the duration, as you can see, a wider here. This is the more gray is actually marking the MR, and the mid to late peaking are actually marking the LVOT. However, that trick's not always helpful, so that's why the angulation actually helps, because sometimes we actually, due to increase in velocity, we can occasionally find that increase in velocity in early systole causing a more rapid, and the peak velocity can be a little bit more rounded or more symmetrically shaped, actually. So that's very important to identify that it's actually an LVOT obstruction. So here to the left, showing the dagger shape, typical LVOT velocity, but here also an LVOT, symmetrical LVOT velocity. And this is from the Canadian guideline. It's like a nice table that actually, like the steps we usually follow. So we usually, by imaging, we look if there is flow acceleration, if there is a SAM, or there's a chordal SAM. Then we go on to check if there is a mid-cavitary obstruction, if there is apical obstruction, if there is a multiple level of obstruction. Have we done any Valsalva exercise by bike or treadmill, other provocation by medication, or by the postprandial exercise, and after that, is there some worsening or not? So then we go to assess the MR severity and etiology. So tips that usually because of the anterior leaflet get dragged toward the LVOT, so having a posterior directed MR is usually what we see in patients with hypertrophic cardiomyopathy. If the MR is anterior directed, we need to look for an intrinsic valve disease. And if the patient imaging is suboptimal, we always can do TE to further identify the MR severity, and usually in the mid-esophageal and transgastric view, we can actually provide a detailed assessment of the mitral valve apparatus. However, in some cases, non-posterior directed MR can still be related to SAM because of a difference in leaflet geometry that alter the direction of the jet. But as we mentioned, if we find that the patient, we need to look carefully for other causes like mitral annular calcification. In 3D, we can look for mitral valve prolapse, also in 2D as well, rupture chordae with a flail leaflet or abnormal leaflet with the valve. And we also look for the morphological expression for hypertrophic cardiomyopathy, like abnormal insertion of the pulmonary muscle or periendocarditis that actually can cause MR to be not posterior directed. So after that, we go to the next step for the risk stratification. So in order to talk about the risk stratification, so our patient actually at higher risk of sudden cardiac death. So there is few parameters in echo we need to follow, including the massive LVOT, the apical aneurysm, and the ejection fraction. So from the, so this table from the ACC Hypertrophic Cardiomyopathy guideline, so it says that our patient is at risk if the patient have an ejection fraction by echo or MRI to be less than 50%, or having an apical aneurysm actually can increase risk of sudden cardiac death as well. And we also can look by MRI for the percentage of the late gadolinium enhancement as well. And the thickness of the wall, if it's 30 millimeter or more, can also increase the risk as well, regardless if it's in echo or MRI. So in echo, we need to measure the only compacted myocardium with excluding of RV structure. And we also need to cross-check with at short axis. So we can actually cross-check with short axis because we don't want to include we don't want to include trabeculation or papillary muscle, and we want to do it in LV cavity with avoiding of foreshortening. So you can see here they measured it to be around 13 millimeter. However, when they actually went in short axis, they found out that they actually is only 10 millimeter. So also it's important to know that our patient can have an apical aneurysm that can increase sudden cardiac death along with thromboembolic event. And if we don't do contrast for our patient, as you can see in this example, the patient did not have an obvious apical aneurysm, but when you use the contrast, there was actually an apical aneurysm. And that's why our patient also need to do an MRI to rule out apical aneurysm. Then we go to the next step, which is actually interesting, which is actually identifying the phenotypic expression of hypertrophic cardiomyopathy. So a number of other morphological abnormalities that is not diagnostic for hypertrophic cardiomyopathy, but can be a part of the phenotypic expression of the disease, including having hypertrophied and apically displaced papillary muscle, anomalous insertion of the papillary muscle directly into the anterior leaflet in the absence of chordae tendony, having an elongated mitral valve leaflet, having a myocardial crypts, myocardial bridging, and right ventricular hypertrophy, which we're going to talk about it in details. So first, we're going to talk about papillary muscle hypertrophy. And this is common actually in patients with the hypertrophic cardiomyopathy. And the definition for that is having at least one of the two, the anterolateral and the posteromedial papillary muscle, having a diameter of more than 11 millimeter in short axis, or a combined mass more than 7 grams per meter square. And this is, as we mentioned, is common in patients with hypertrophic cardiomyopathy. And the way it's affecting the patient, that in such patient, the distance between the septum and the anterolateral papillary muscle is reduced because of the thickened septum and hypertrophied muscle, thus narrowing the LVOT. Another phenotypic expression of patient with hypertrophic cardiomyopathy is having an apical displacement of the papillary muscle, and it's actually also common in patients with hypertrophic cardiomyopathy. And you can see from this picture, usually in patients, and normal patients, the attachment of the papillary muscle actually happening in the middle third of the leaflet of the left ventricle. It's happening in the middle third of the left ventricle, while in patients with hypertrophic cardiomyopathy, they can have an apical displacement of the papillary muscle to be happening at the apex, and that actually can affect the patient as well. So the apically displaced papillary muscle may actually cause an apical shift of the mitral valve, and also with the abnormal chordal connection that coexist, that actually both this condition along with the elongated leaflet may result to an exposure of the mitral valve coaptation area to ejection flow, and thus facilitating development of SAM and the LVOT obstruction. So in addition to that, the patient can have a bifid papillary muscle, as you can see here from this picture, that will make it more hypermobile than the normal one. And that will actually also facilitate LVOT obstruction by shifting the papillary muscle, leading to edge toward the interventricular septum during systole, even in patient without significant increase in LV wall thickness. In addition to that, the patient can have, as we mentioned earlier, they can have an abnormal insertion of the papillary muscle into the mitral valve leaflet, although it's uncommon, but it actually has a great clinical significance with the insertion into the anterior leaflet, which is always related to the LVOT. In addition to that, the direct insertion of the anterolateral papillary muscle into the anterior leaflet may lead to mid-ventricular obstruction. In literature, they actually have even subtype for that abnormal insertion. And as you can see, there's a different insertion of papillary muscle into the anterior leaflet, and each type has a different expression. Like, for example, in type 3, this variant, as you can see here from C, this variant does not cause subaortic obstruction, but may contribute to mid-ventricular obstruction at the level indicated by the arrow. Then going to the last part of our presentation, which I find the most interesting, is actually differentiation from the mimicker, because obviously if the diagnosis is not hypertrophic cardiomyopathy, then the management will be different. So we need to rule out differential, because if the patient have a thick wall, they can have hypertrophic cardiomyopathy, but it can be related to hypertension, it can be related to metabolic disease or multi-organ syndrome, or a patient can have a mitochondrial myopathy, or they can have a Fabry or amyloidosis, sarcoidosis, hemochromatosis, or Danon cardiomyopathy in adult. And this nice table from the American Society of Echo illustrates by age what is the disease we mentioned, and the diagnostic approach for such patient. So it's important to keep an open mind that hypertrophic cardiomyopathy can be noticed at any age. In late age, it can be related to aortic stenosis. Athlete usually in a younger age, Danon in a younger age, Fabry usually a little bit in later in age. So, but again, age can help us, but we need to look at other parameters as well. So when we start assessing our patient, so we need to look for other features that can help us guide us to know which patient or which disease the patient has. So we start usually by clinical symptom, and after the clinical symptom, we go to the ECG. So if the patient having an LVH with and repolarization change, so it can be hypertrophic cardiomyopathy, but it also can be hypertensive heart disease, or it can be an athlete and individual with Afro-Caribbean descent. If the patient have a short PR or pre-excitation, then it can be related to Fabry, Danon, or if the patient have a low voltage, it can be related, or the pseudo-infarct pattern we see in amyloidosis, it can be related to amyloidosis. Or if the patient having a deeply inverted T wave, it can be related to apical variant of hypertrophic cardiomyopathy. Then the most common question we face is if the patient having a hypertension, is this actually LVH related to hypertension or hypertrophic cardiomyopathy? Well, if the patient having a very thick heart, it's more easy to answer, because hypertension does not usually cause severe LVH beyond 18 millimeter. But the problem happens when the patient having an LVH between 13 to 18 millimeter. And we have to remember that our patient can have both diagnoses as well. They can have hypertension and hypertrophic cardiomyopathy. So these are the clues to help us differentiate between hypertension and hypertrophic cardiomyopathy. So if the patient have SAM, the systolic anterior motion, and phenotypic expression of the mitral valve, this can be related to hypertrophic cardiomyopathy. If they're having a maximum anterior septal thickness, 18 millimeter or more, that's more in relation to hypertrophic cardiomyopathy. If the patient having a pattern will be hypertrophy predominantly involving the apex, anterolateral free wall, or the posterior septum, that can be related to hypertrophic cardiomyopathy. Or if you have abnormality, prominent or diffuse late in the LGE. What about amyloidosis? Well, amyloidosis is one of the interesting disease, and it shares a lot of features similar to hypertrophic cardiomyopathy. So they both have an increased wall thickness, and it's sometimes difficult to differentiate between both. But despite that, both can have a thickened valves. But if the patient have a more pericardial effusion, if they have a sherry on top in the GLS, and if they have, for example, those features can actually help us to actually know if the patient having hypertrophic, patient having amyloidosis. Also, the sparkling appearance, which can aid in diagnosis of amyloidosis as well. And the GLS also helps as well, because in hypertrophic cardiomyopathy, the systolic strain rate abnormality appear co-located mostly, but not exclusively, with the region of the hypertrophy. While in patient with amyloidosis, is usually sparing the apex, and we have the sherry on top pattern. And the ECG also in amyloidosis in the top, you can see that they have the pseudo-infarct pattern, and sometimes they have a low voltage. But if the patient having a high voltage and repolarization abnormality with ST changes and the T-wave inversion in the apical version of hypertrophic cardiomyopathy, the patient actually can have hypertrophic cardiomyopathy. Again, absence of low voltage in ECG does not rule amyloidosis as well. So it's important to look from everything, from the clinical picture, from the ECG, from the echo, and MRI can help as well. And as we mentioned, that amyloidosis and hypertrophic cardiomyopathy can actually, MRI can help into identifying the pattern as well. Differentiation between athlete and hypertrophic cardiomyopathy, that's important. So usually in hypertrophic cardiomyopathy can be distinguished from a physiological athlete by having obviously a cardiac symptoms, having a more thick heart, having a normal or small LV dimension, and evidence of diastolic dysfunction. Obviously, if you have a diastolic dysfunction, that's in relation more with hypertrophic cardiomyopathy, and having some as well, an obstruction that actually more in favoring with hypertrophic cardiomyopathy. So, okay, in conclusion, hypertrophic cardiomyopathy is now recognized as a more common condition, and the assessment is essential for and thorough assessment is essential for effective management. Absence of obstruction at rest should not, we should not stop at that point, and we need to rule out obstruction by other maneuvers. Papillary muscle abnormality are common in patients with hypertrophic cardiomyopathy and have an impact in surgical planning, and differentiation from mimickers is a must for proper management. Thank you so much.
You still have 15 minutes left. So thank you. So any questions from the audience? So this is a very comprehensive review of hypertrophic cardiomyopathy from different aspects in terms of identification, definition, assessment of gradients, mimickers, especially with epileptic hearts, as well as apically displaced pec muscle, which is often what we see. So any question? So I'll start first. Often we see patients just show up in our office. They may or may not have sigmoid septum, and they have intracardiac gradients. Okay, so they may not even have symptoms. We just incidentally find them. So often they have, like, sometimes sigmoid septum in older people, sometimes hypertrophy, papillary muscles, and they have mid-cavitary gradient, but they're not symptomatic. So is it important to treat the gradient just alone with or without symptoms?
So usually, like as we mentioned, we need to look at the patient in a comprehensive manner, in which we look for other phenotypic expression. We need to look if there is systolic anterior motion or not. If there is an obstruction, if the provocal obstruction, and to look and to stress on the symptom. Maybe the patient actually have symptom that's actually not, but it's not related. So we need to alert the patient if they have an obstruction. If the patient get dehydrated, the obstruction will happen. And that will actually can push the patient to syncope and can push them into more symptom. But if the patient is completely asymptomatic despite doing the maneuver, despite exercise, we need to follow up that patient. And because does not having an obstruction now, he can have an obstruction in the future. And depending on the gradient, if the gradient is too low, even with provocation, that can be reassuring, but with a follow-up in the cardiology clinic. But if the patient is having more with the obstruction and more with the symptom, then we need to follow them closely.
Okay, so often I'll tell them drink more water.
Yes.
Which is when people do not, for some reason, at least 8 cups of water, and also consider beta blocker or rate lowering CCBs or calcium channel blockers, such as Ditizem. We don't use verapamil very much in Canada. How about if patients only have no gradient at rest and only gradient with Valsalva? And sometimes we see that too.
Yes, but if they are having gradient with Valsalva with symptom that considered an obstruction, it's a provocal obstruction, but the patient, in their daily activity, they can actually have more symptoms. So even if there is nothing at rest, it can happen during their daily life. So that's very important to notice as well.
So then should all of them have stress echo?
If we have a patient no gradient at rest, we need to do stress and we need to do provocation if they are having a symptom or expression of hypertrophic cardiomyopathy.
Okay, questions from the audience? Matthew has a question. So,
is there a rest gradient at which we do not need to do any provocation?
Yes, actually,
let's repeat this. Let's repeat the question first. So Matthew, one of our sonographers asked the following: is there a threshold or level of gradient at rest that you would not do Valsalva maneuver, either too low or too high, I guess?
Sure. So I think we're still going to do it because we want to know the magnitude of the obstruction that the patient is having, because it actually can guide us toward if we're going to do a septal reduction therapy or not, if we need to maximize our treatment or not. So I think doing the provoking maneuver is still valid actually in such patient.
Yeah. So maybe I'll just add to that. From a more practical standpoint, I mean, we need your help. As I mentioned, sonographer is really the most important element in our whole discussion here. Is we need you, if you have any concern about them having gradients, for example, they have sigmoid septum, if they have, observable 2D sort of observation of capillary obliteration either at the apex, mid, or outflow tract level. Even though if they don't have any gradient at rest, one would consider or do a provocation maneuver such as Valsalva. That's another one. What else is there situation that we should definitely do it? If the walls are very thick, that we should do provocation to make sure that they don't have gradients. The other thing is the opposite. Now, if it's too high, at what level do we not have to do it? Like sometimes we have patients who present with a gradient of 25, 35, 45, 55, 60, 70. At what point, let's say in Ottawa, like would they not do any more provocation? Because now you have it.
Yeah, I think if it's actually like obvious the patient having same-infect obstruction, we might stop at that level just to make sure that we don't cause any problem during the test.
I don't think we have an absolute cutoff, but in my mind, and correct me and please add to this conversation, is I think once we see like 50 rest gradient, there's no need to do Valsalva. It's high enough for us to deal with it. But sometimes when you have like, borderline 30, 35, 40, 45,
for sure,
not entirely sure. So sometimes we would do provocation up to that point. So I think, again, clinical suspicion of having obstruction, yes. So rest and Valsalva. And then the other thing is that if it's too high, let's say 50 or above peak, then you don't actually need to do Valsalva. Just make it worse.
Jiming, if I could add to that.
Oh, yes, please.
So I think, in the past, I think 50 was sort of the cutoff of significance. But now I guess we do 30 because of. So I don't mind doing it between 30 and 50. I don't think there's a right or wrong answer, but I agree with you. I think clear cut above 50. Like you all know, you do a good Valsalva, it's going to increase. Yeah. I'm not sure whether or not it increases to 100 or makes that much difference clinically. So I don't think we necessarily need that. Now, if it's 30 and it's kind of around 30, I think to really be something sure, then doing some provocation is acceptable.
I think just having 50 is a good number to remember, is easiest for all. And for Mount Kempton, I think the government cutoff might actually be 50. Was it 50 for some of the coverage? So definitely, like, whether they're provocable or not. So if it's 50, if it's below 50 at rest, I would definitely think there's a role for it, and over 50 not necessarily.
So we have a consensus of 50. So remember that 30 and 50, right? 30 or above, yes.
Make it easy, just remember 50. You see
Okay.
50, stop. Don't see 50, try.
Keep going.
So clear cut 50, not 50 and just stretching it all the way down.
So one of the problems is not all patients can do an effective Valsalva. So there was a time when we had amyl nitrate, which was great because it worked really, really well and pretty standardized. We don't have that option anymore. So there are devices that people have invented that sort of help you with Valsalva. I don't think we have them in our lab. Should we?
That's an interesting. I think they were talking to Qiming about this. At least the rep was telling me that she was talking about this, like whether they can train them to do Valsalva with some tool, right?
I was going to ask that question next. What would be actually a good Valsalva? So we had Dr. Emerjory from Kingston who came and actually shared with us his experience and his slide deck that is being used around the country to do really good gradients because of the importance of the myocardial inhibitors such as mavacamten. So what would you do? Like, what in between Hamilton, Ottawa, and Saudi, what's your experience about how do you actually standardize or have a good Valsalva maneuver?
So we actually ask the patient to bear down and try to sometimes we can make sure the patient, I am asking to simulate like in the bathroom, push very hard, and when I ask you to release. And if the patient is not able to do that, then we go to the next step. Is actually we ask them to do the exercise, which is most patients will be going to be able to do it.
Okay, so but yes, this is normally what we would do. The challenge would be, language barrier is a problem, ability to follow instructions, and also, some people with stroke may be a little bit harder to follow these instructions. Any device that you have come across in your travels that can make it more standardized? Any? They always thought of actually inventing, or we can 3D print one. So, to make a business out of it.
There is a device, isn't there, that you blow it?
They have, like, the merch docs use the 10cc syringe as a modified Valsalva for to break SVTs, right?
Yeah, actually, William tried to do that with one of our patients, and unfortunately, it didn't really work.
Yeah, I haven't had much success with these.
Yeah.
At least for breaking for SVTs, I haven't had much help. But
yeah, my patients kept telling me all the stories about going to Emerge, and then Emerge people actually use I think they call it the reverse syringe. So you give them a 10cc syringe, and then you try to blow the plunger out. So that's what they're explaining about converting AVNRTs or things like that. So it's not unreasonable to try that. This is for some of our patients, maybe it's considered a very simple echo project, maybe either for echographers as a project or as a echo fellow or combined, venture and tried it out and see what happened. So,
the other thing that's simple to try, doesn't work well in everyone, is at the end of the study, get the gradients with the patient standing. Like, it's amazing in clinic how often just standing a patient up brings out a much louder murmur, and that's one thing to do. And the related comment to that is the type of exercise to do. Ideally, I think it is better if you can do treadmill versus recumbent bike exercise for similar reasons.
So there you go. That's Dr. Parker, one of our resident experts in hypertrophic cardiomyopathy. So thank you for the
So that's back in the old days when we actually listened to patients with a stethoscope. The squatting and standing was routine.
That was one of my videos that I made when I was at McGill, like as a resident, to actually teach. One of my first website-based video for teaching physical exam is how to actually accompany elderly patients. You would actually put them in between you and let them go up and down and listen to the stethoscope. Maybe that's another thing that one could do in echo, whether you can actually get a gradient sitting up or standing up. Do you think you could do that? Do you think you can actually get a? It's hard enough as it is to get a gradient lying down.
Yeah. Actually, I've seen it done before, Chi-Ming. You know, you don't always get great tracings, but a blind probe on a standing patient often works.
Okay.
I was telling Jeremy that I don't know if you remember, Tom, my Ursula Banks project when I was a resident was with Brian O'Kelly. And so it was a small study. It was my very first abstract to ASE. It was ASE in Washington, DC. It's where I met Sanjeev Kaul, actually. But it was, we took HCM patients and we actually had them do upright bike. So they're actually on an upright bicycle with simultaneous echo for, I didn't do this, I versus the scattering.
Thank you.
Supine bike versus upright bike simultaneous, doing exercise versus amyl nitrate. Because we used to use amyl back in those days. Small study, I was telling Jeremy that overall there was variability, but relatively equal with all of the human units. But it was variability. Some patients had slightly higher with one versus the other, but not that different. So I'm not sure if there's a huge difference between because I think the problem is all of the provocable maneuvers have their own variability. So I think that's a
Okay, I completely agree. So, you know, it's a HO question.
never published it.
Well, never too late to repeat that.
Yeah.
Okay, so here are some questions from the audience from the chat. So in difficult parasternal views, any trick to improve accuracy of measurement of septum?
Sure. So actually what we can do is actually we can give contrast, because sometimes contrast can actually show us how much is the septum from the parasternal long axis. And obviously positioning the patient on the left lateral decubitus will bring the heart closer to the chest wall. And actually, or sometimes returning the patient back to his back, or in an angle in between can actually show that parasternal long axis view very clearly.
Okay, interesting. So there's an interesting device on the internet. We'll see whether we could find it.
So while you're doing that,
Yep, go ahead.
especially with Dr. Parker on the line, the issue of progression of hypertrophic cardiomyopathy over time. So, you know, especially in, you know, if you have a patient who's got genetic predisposition, has hypertrophic cardiomyopathy with the genetic marker, so you're echoing family members, often younger.
Yes.
And they do or they do not have hypertrophic cardiomyopathy. What's the protocol to follow them, because they may actually develop it over time?
Yes. So at first we need to know that not all patients actually have the typical sacromeric hypertrophic cardiomyopathy with the genetic type. They can actually have hypertrophic cardiomyopathy without the genetic. So for patients who are genonegative with a family of genopositive, we don't need to follow them. If the father has a positive gene, but the son does not have a positive gene, no follow-up is required for such patient. However, if the patient is actually the father, if they're having a genopositive but no echo parameter, then we need to follow them. We can do an echo for them annually or every couple of years in order to actually see if the patient developing that hypertrophic cardiomyopathy was during follow-up. Also, it's important for such patients who have hypertrophic cardiomyopathy as a part of their assessment to do Holter to rule out sustained or non-sustained VT, atrial fibrillation, because this all of the risk, like for the follow-up for such patient, because they are at high risk of developing stroke, if they're having significant disease, and they're actually at risk of developing sudden cardiomyopathy as well. And all of that, it's important to know that the risk calculator has been updated for the sudden cardiac death. So we actually need to factor in all those parameters to actually the patient, maybe he does not need or require an XCD now, but he might require it in the future as well. So that is all that put in consideration.
So Dr. Parker, I wonder, how do you follow these genetic positive, but they don't have the echo parameters over time.
Yeah, so first degree relatives, the general thinking has been the greatest risk of development of phenotypic signs is through the teenage growth years. So the recommendations are actually every 2 years up to age 25 and every 5 years thereafter in genetically negative. Probably some of the obstruction that we see in elderly patients may actually have underlying genetic variants for hypertrophic cardiomyopathy, and then the normal contributions of hypertension, the shape change between the aorta and the septum occurs, and it can come on at that age. But in genotype negative, phenotype negative adults, it's every 5 years with echo screening.